Yeah. Welcome all of you to the PG webcast today. Today the discussion will be carried out by Dr. K.G. Ravi Kumar, our senior consultant and endocrinologist, and of course I'll join him in continuing the discussion. And we have a second year DNB PG, Dr. Srilata, who will be presenting details of an adolescent girl with prolonged fever. Is that right? Okay. Go ahead, Dr. Srilata.
Good afternoon, one and all. This is regarding Vishnu Priya, who is an 11-year-old female hailing from Chittoor district, informant being mother. Information is reliable. She was brought with history of rash and fever since 4 months, joint pain since 3 months, and neck swelling since 1 month. She was apparently well, happy school-going girl till 4 months back. Later, insidiously, rash started over the malar aspect as initially macular rash, later coalescing to form a patch over both the malar aspect of the face, which gradually progressed over the neck, arms, and over the chest and then the abdomen. And the gradually progressive rash was papillosquamous, multiple lesions were there with no well-defined margins.
On history, I don't think you can say papillosquamous or what type it is. How did you elicit that history? The history is just about a rash which started in the face, and which part of the face? Malar, you said, that means the cheeks.
Yes.
Is the bridge of the nose involved or perioral area involved? Which part of the face is involved?
The nasolabial.
What was the spread? What was the extension and spread of the rash?
The nasolabial folds were spared, sir.
Okay. Why are you mentioning nasolabial folds? How is it important?
Because in dermatomyositis there is involvement of these nasolabial folds.
Yes. So dermatomyositis, nasolabial fold is involved, whereas in SLE there is a sparing of nasolabial fold. And what about, is there any significance of perioral area, sparing of perioral region? What does it signify? In a lot of conditions like scarlet fever and such conditions, even dermatomyositis, perioral region is spared. Okay, for some unexplained reason. Okay. I think the description of the rash as a macular, papillar and all that from the history is difficult. I don't know even how good the history is from this mother, but even a very intelligent mother would be difficult to elicit that history. Okay, carry on.
She initially told it was dotted, sir,
okay.
And then it formed a patch.
Okay.
This rash was non-itchy, not associated with any pain, non-tender, and it was occasionally associated with burning sensation when she used to go out and for school.
Okay.
This rash is associated with fever, joint pains and oral ulcerations, which I would describe further, sir. There is no history of any drug intake prior to this rash, no history of any headache, myalgia, muscle weakness or gait abnormality, visual disturbance,
Okay.
and foreign body sensation of the eyes, any nail abnormalities, no throat pain, no breathlessness, palpitations, no not associated with any abnormal movements.
So what you described is the systemic manifestations of a connective tissue disorder like thing. How did you come to arrive at a conclusion this is a connective tissue disorder from the history? Any child with a rash, it could be infectious, it could be malignancy, it could be connective tissue. Was there any pointers from the history to lead you on to this type of history?
This rash had a waxing and a waning course, sir. Whenever it comes, it stays for about 10 days.
Okay.
It fades, but it is present, but it fades, sir.
Okay.
Fades off.
One more thing you mentioned, it increases on going to school. What does it mean?
For photosensitivity.
Photosensitivity. So what does it indicate? Photosensitive rash.
It is present in connective tissue disorders like SLE.
Okay. Okay. So more towards connective tissue disorder. So you have mentioned about all the negative history from that point of view. Okay, carry on.
Fever was sudden in onset, high grade. It was not associated with any diurnal variation. And fever was continuous. It does not subside with routine antipyretics, sir. Each febrile episode lasts for about 7 to 10 days in a month. And this has been happening for the past 4 months. This fever is associated with weight loss, which is more than 10%, 2 kgs over the last 2 months. And it's associated with increased fatigability. Child prefers more to sleep even in between the febrile episodes. It disturbs the child's routine activities. She finds it difficult to go to school and she doesn't play much. The fever is also associated with oral ulcerations, which were predominantly over the roof of the mouth, tiny discrete ulcers, and when it was present, it was also associated with redness of the tongue.
Can anybody tell me what does it indicate, oral ulcers in a child with a fever? What are the differential diagnoses that comes to your mind? Any of the from the audience? Which ones? Vitamin deficiency. What did he say? Viral infections. Okay, such as herpangina. Okay, herpes. Okay, Pfeffer's ulcers. Okay. So first we think about infectious cause that can cause a prolonged fever associated with a rash, associated with a oral ulcer. Okay. Any other cause? Any other?
Vitamin deficiency, riboflavin deficiency.
HIV, vitamin deficiencies, riboflavin deficiency. Okay.
Inflammatory bowel disease.
Inflammatory bowel disease, especially when there is loss of weight. You said the child is easy fatigability and loss of weight recently. One has to think about inflammatory bowel disease like Crohn's and ulcerative colitis. Although these are rare. Okay. What are the more commoner things? Okay. So oral thrush associated with the HIV infection or a chronic immunosuppressed child. Okay. Any other thing? What about celiac disease? Has anybody mentioned about celiac disease? Celiac disease with oral ulcers and weight loss. Although fever is not explained. Okay. Other connective tissue things like Behçet's syndrome, Behçet's, all have to be thought about. Okay.
When you have oral ulcers, or for that matter ulcers in the oral cavity, there are 5 groups of etiological factors which need to be kept in mind. Infection, malignancy, autoimmune disease. In addition to these 3, we have to remember 2 other important groups in oral ulcers. One is drug induced, the last group is nutritional. By and large, most of the oral ulcers will fall into these 5 groups. And she specifically said the ulcers are painless, isn't it? Are they painless or painful?
Painful, sir.
Painful. I think first you said rash was painless. Sorry. If it is painful and painless, does it have any significance?
Yes.
So there are 2 children, one who has an oral ulcer which is painful, another who has an oral ulcer that is not painful. Does it make a difference to you?
Yes.
Anybody in the audience? No, is it?
Is the SLE rash painful or painless? Painless. Pfeffer's ulcer?
Painful.
See, you must remember the most common oral ulcer is an aphthous ulcer, and it is exquisitely painful. One must have an aphthous ulcer to know the pain of it. It is very, very painful, right? And in fact, it will be so painful that the intake will be affected. and all other oral lesions due to infections. For example, the commonest oral lesion which produces a painful ulcer today in OPD practice is, can anybody tell me what is the commonest? Herpangina. The mother will give only a history saying that there is fever and the child is having throat infection and drooling. The child won't swallow. And you, unless you see the soft palate where you will get ulcers, it will be missed. So, second thing is, if you have an oral ulcer, you must always ask whether the oral ulcers are persistent or whether they are appearing, reappearing and disappearing. What's the significance, Srilata? Oral ulcers which are persistent, oral ulcers which come and go, what's the difference between the two?
Sweet syndrome, sir. There.
No, you have, again, I'm giving you a case scenario where there are two children. One has persistent oral ulcers for 3-4 months, and another gets oral ulcers periodically.
If it is persistent, then it's because of immunodeficiency, primary or secondary immunodeficiency syndrome, sir. If it is on and off, maybe.
Anybody in the audience?
Viral infections. If it is persistent, we'll think of malignancy or vasculitis.
See, basically malignant oral ulcers in pediatrics are very uncommon. Very uncommon. Remember, if a child has a persistent oral ulcer which is not responding to topical therapy alone, it indicates a serious underlying inflammatory disorder. On the other hand, if a child has got an aphthous ulcer, which I give you a case scenario, every 28 days mouth ulcers come, fever comes, what's the first diagnosis? Huh? Every 28 days there is fever and mouth ulcer. Cyclic neutropenia, cyclic neutropenia. Periodic, that's a characteristic condition. Because the other condition which causes mouth ulcer and recurrent tonsillitis. Every 4 to 8 weeks fever, tonsillitis, mouth ulcer. Again periodic fever, aphthous stomatitis
periodic
syndrome.
fever syndrome.
What is the other name
Periodic
for it?
fever.
What's the other name for it? Huh? PFA-PA syndrome, isn't it? Right? Right? That also you get aphthous ulcers, tonsillitis periodically. On the other hand, if you have a child with SLE, or for that matter, if you have a child with inflammatory bowel disease, unless the disease activity is suppressed with therapy, the ulcers are likely to persist. They won't disappear spontaneously. It's very unusual for a child who has got a chronic inflammatory disorder to have natural remission. Unusual, it can occur, but by and large it doesn't occur. Right?
Because of this aphthous ulcer, she is not able to take orally. It's associated with poor oral intake.
I am interested in knowing from you, you said there is increased fatigue in the child.
Yes.
What are the conditions in which a child comes to you with increased fatigue?
Cardiology.
What is the commonest cause for
Anemia.
increased fatigability in a child?
Anemia, sir.
Okay. Ravi Kumar is sitting close by me. Fatigue
This
does
child
not
is
occur.
losing weight.
Losing weight, fatigue,
Diabetes.
becoming dark. Yeah, I'm giving you enough clues with Ravi around.
Dark pigmentation, creases.
Adrenal.
Addisons. In fact, it is, you must remember, in fact, there have been reports in literature where children receive inhaled corticosteroids. The only symptom of adrenal suppression may be increased fatigability. Their pituitary adrenal axis may well be subclinically depressed, and that may be the earliest symptom. Right? What are the other causes? increased fatigability. Any chronic illness, right? Any chronic systemic disease, right? Anything else?
Cardiac, somebody mentioned.
What is the commonest cause of increased fatigability in an adolescent? Adolescent, that too during March and April.
Heat stroke.
Huh? Stress, yeah, emotional stress, perhaps the most common cause, right? Most common cause. Anything else? Have you heard of chronic fatigue syndrome? Is it there in pediatrics or not there? Yeah, yeah. And what are the etiological agents that have been attributed to, that are being implicated in the cause? EBV, HIV, chronic viral infections, right? And increased fatigue may be a symptom of hypocalcemia also rarely. Not usual, but it can occur, right? Children who have recurrent episodes of hypoglycemia, they can present with fatigue, right?
Is
Chronic
also
renal-
proven as a genetic cause, is also proven as a chronic fatigue syndrome. There's also genetic etiology and the virus infection.
Children with chronic renal disease is present with fatigue, right? Cardiac disorder, of course, no question at all, it does present with fatigue. Any child who has a chronic hypoxia secondary to a pulmonary or a systemic disease can have fatigue, right?
What about tuberculosis? We've spoken about everything except our national common thing. You think this will fit in with the tuberculosis?
Rash is
Rash is unlikely, oral ulcers are unlikely, but
unlikely in
easy
tuberculosis.
fatigability, loss of weight, and the fever episodes, one has to think that in mind as well. Common
There's
things
no
are
history
common.
of any TB contact.
There is no contact, okay. And lymphadenopathy, this child, okay, we'll come to that on examination.
Can tuberculosis not present with rash? And if it presents with rash, what rash can occur in tuberculosis? Erythema nodosum, notorious manifestation erythema nodosum. You can have various types of cutaneous tuberculosis. Only thing is, they are not manifestations, as Ravi said, they are not manifestations of systemic tuberculosis, disseminated. They are isolated. Okay, erythema nodosum is, what is it? Erythema nodosum is a manifestation of disseminated tuberculosis or primary tuberculosis? Primary tuberculosis. It's a hypersensitive phenomenon where immediately following manto conversion or tuberculin conversion, you get a manifestation in the form of a erythema nodosum. Can occur, right?
This fever was not associated with any dysuria, hematuria, headache, altered sensorium, seizures, jaundice, melena, hematemesis, bruising, or pallor. Joint pain started along with fever subsequently, initially in small joints of hand and foot, and gradually involving the bilateral knee joints and left elbow joint. Left elbow joint had tenderness, whereas the other small joints were not associated with any tenderness, joint stiffness, joint swelling, and there's no sleep disturbance because of this joint pains. There's also no gait disturbance because of this joint pain.
What is the pattern of joint involvement? Did one joint get better before the other joint got involved? Or everything happened at the same time?
No, sir. Initially, it was only the small joints. And initially, hand joints were involved, the two small joints of hand. Later, it gradually subsided. Later, small joints of foot were involved. Later, it subsided. And again, had left elbow joint.
So when you say subsided, the joint symptoms are completely gone, like it happens in rheumatic fever. Rheumatic fever licks the joint, it completely gets better. Is it?
It's not completely gone. It was subsequently
So
better, but still.
The pain continued. So that's very important. In connective tissue disorders, the pain will continue with joint symptoms becoming more chronic.
And, neck swellings were noticed 1 month ago in the anterior aspect of the neck, multiple and they were not tender, they were not increasing in size. And for these above complaints, she has required multiple hospitalizations. She has received IV antibiotics and oral medications. Blood investigations were done and chest X-ray was done, and a needle aspiration from one of the neck swelling was taken and was advised for further follow-up. And since the fever was persisting, they've referred here for further management. After coming here, blood investigations were done, eye checkup was advised, and ultrasound abdomen was advised. The parents have understood that this is a long-term problem and it requires treatment, long-term follow-up and treatment. And child has not attained menarche so far. However, the mother's age of attainment of menarche was 14 years. Now, currently the child is ambulatory, afebrile, and afebrile.
Any other history suggestive of rare things like Raynaud phenomenon or any nail involvement, alopecia, all those are part of the generalized connective tissue symptoms?
History of alopecia was noticed over the past 10 days, sir.
Okay.
But there is no patchy loss of hair that was noticed. And there is no history of any bluish discoloration when the child keeps her hands in cold water.
Okay. In SLE, the patchy loss happens first in the temporal areas, temporal regions, and then progress, but it can be patchy also. What are any other cause of alopecia? What are the causes? Any other cause of alopecia that you can think of?
Hypothyroidism.
Okay, hypothyroidism is one.
Fungal infections.
Vitamin deficiencies.
And, any child on chemotherapy.
Okay. Addison's, diabetes mellitus, thyroid, particularly autoimmune thyroiditis. Right? These are the three important endocrine causes for alopecia. Right? And don't forget alopecia due to vitamin D hypocalcemic type 2, isn't it? The receptor defect, 1-alpha hydroxylase.
Yes. She is the second born to non-consanguineous parentage, term child. Birth weight was 3 kgs. The other sibling is normal. She is all girl. There is no history of abortions in mother. She is a developmentally normal child with good scholastic performance. Bowel and bladder habits are normal. Sleep pattern, she has disturbance in sleep pattern. Onset is normal, but in the middle of the night she awakens and she again sleeps. Dietary history, she's taking 978 calories against...
what has happened to her schooling in the last 4 months?
She's not attending school, sir.
That's very important. You should mention that. Right? Because that the impact on the child's normal living due to the disease has to be found out, whether it is asthma or whether it is anything, any chronic disease, right?
She is receiving 978 kilocalories against a requirement of 1970, calorie gap of 1000 kilocalories. Protein 0.7 gram per kg per day against a requirement of 1.45 kilocalorie per kg per day. Per grams per day. She is immunized up to 7 years as per the national immunization schedule in government setup. There is no history of similar illness in the family, and she belongs to lower middle class according to modified Kuppuswamy scale.
Okay, can you give a summary of the history so far?
Get the child. Call the
You want
child. Vishnupriya is a 11-year-old female who was apparently well school-going girl till 4 months ago. Later, subsequently had rash which was waxing and waning in course for the past 4 months, associated with fever which was recurrent for the past 4 months, and associated with joint pains which had a waxing and a waning course involving the small joints and also one large joint, associated with neck swellings and oral ulcerations, associated with significant poor oral intake, disturbing her daily activities with associated with school absenteeism. Probably
So which system is involved with this history?
multi-system involvement. So one is the skin and the joints
Okay.
and lymph nodes.
And which are the systems involved in this child?
Musculoskeletal system, sir,
Why do you say musculoskeletal system is involved?
because it's involving the small joints and one of the large joints also.
So it's basically skeletal, isn't
Yes.
it? Skeletal. Joints are involved.
Yes,
Huh? That is one. What next?
and then skin, sir.
Skin is involved. Skin is involved.
Yes, sir.
Right? Two.
Then lymph nodes,
If lymph nodes are involved, what does it mean? Which system is involved?
reticuloendothelial.
Huh?
Reticuloendothelial.
Reticuloendothelial system is involved. Lymphoid tissues are involved. 3, 4.
Then GI, sir.
Why do you say GI?
Oral ulcerations.
Oral ulcerations are, you want to call it GI? Mouth, you call it as GI?
starts from
Huh?
Part of it.
Part of it. Part of it.
Maybe
GI
part of
system.
it.
GI. Okay, mouth is involved. What does it do? Is it mucosal involvement?
yes.
Mucosal involvement is happening in the mouth, indicating probably involvement of the mucosa of the gastrointestinal tract. What else is happening in this child?
Weight loss, poor oral intake,
Why weight loss is occurring? Which system is involved if there is weight loss? Which system is involved if there is weight loss?
can be
Can be
any system can cause
Any-
weight, but current but
any system. Can this
Since
be an
the-
endocrine cause for a weight loss in this child?
What are the endocrine conditions that cause weight loss?
hyperthyroidism, sir.
Hyperthyroidism. Okay.
Hyperthyroid. Do you think this is
Addison's-
hyperthyroidism?
What are the? Okay, why is it not hyperthyroidism?
There's no diarrhea.
There's a rash which is not explained. Okay.
There are no tremors, and
No
they'll have
palpitations.
palpitations, sir. And fever will not be waxing and waning.
Usually children with hyperthyroidism do not present with fatigue. In fact, rarely they may present with hyperactivity. Hyperactivity rather than fatigue. They are restless and sleepless rather than fatigued or lethargic. So that's against hyperthyroidism.
And joint symptoms also are not explained by thyroid illness, unless it myopathy can.
Yeah, go ahead, go ahead.
Myxedema and myopathy can happen in Graves' disease. Graves' disease, one has to think about autoimmune condition which can cause muscle weakness.
Is the nervous system involved in this child?
She's having sleep disturbance.
No, is nervous system involved in this child or not? Anybody in the audience, is nervous system involved in this child or not? Why you say probably involved?
Sleep disturbance could be due to chronic pain. The child is having joint symptoms chronically. It could be the chronic joint pains. One has to ask why the sleep is disturbed.
I've asked her whether she's awakening because of pain. She said no.
If pain is not disturbing the sleep and fatigue is present, sleep is decreased, definitely one has to think of a central involvement. Perhaps what other questions should you have asked to find out if there had been central involvement in this child?
Any altered behavior, any abnormal movements?
Abnormal behavior, okay.
Any abnormal
Why
movement?
abnormal behavior?
They'll have mood fluctuations.
Yeah,
Can be.
of course, if you are going to think of a long-term disease with rash, definitely you are going to think of SLE, and definitely psychosis and seizures are considered to be the most common manifestations. You have to inquire into what else.
Any abnormal movements, sir?
Did you find out the ambulation of this child? See, you said
Yes.
joint pain and swelling. At no point at the time I heard you talking about how her ambulation had been for the last 4 months.
Whenever she is having severe joint pain, she has difficulty in walking, sir.
Difficulty in walking.
Pain.
Is
she
the
has-
difficulty in walking due to a neurological cause or a rheumatic
It's because
cause?
of pain, sir.
Because of pain.
Pain.
Antalgic gait. Why not she be having an associated muscle weakness also, which could indicate there is associated? So you said fatigue is there. Could she have a muscle weakness in addition to joint involvement?
Sir, she is able to get up on her own from the bed. She is able to walk.
What other
She's-
question you would have asked to find out if she had any associated, say, myopathy?
Is she able to brush her teeth, able to comb her hair on her
Anything
own?
else? Anything else more important than daily toilet? I think the most sensible question would have been whether she is able to squat, and if they have an Indian toilet, whether the child is able to squat and get up. That would have been very, very relevant.
What about the early morning stiffness? That is also one of the signs of.
There is no
early-
joint stiffness, sir.
You know what is gelling? Gelling, Gelling. Gelling is the hands and feet becoming stiff after sitting for a long time, especially after a car journey or in the classroom. When they sit for a long time in the classroom, they find that they are not able to get up. That is called gelling, which characteristically is a feature in SLE and other rheumatic conditions. It's mentioned.
Right? Do you think renal system is involved in this child?
There is no decreased urine output, not involved, sir.
Not
There's no,
involved.
because there's
Do
no
you think the
decreased.
hematological system is involved in this child?
There's no.
Hmm?
There's fatigability, sir, but there's no history of any pallor, sir.
Do you think the immune system is involved in this child?
No recurrent infections noticed.
Fever itself, 4 months fever, recurrent fever, you said,
It can be infectious.
can be associated infection, right? These are the possibilities. If with this history, what do you think is, you said so many problems, what are the problem, fever, rash, multisystem involvement. What do you think is the most probable diagnosis with the history?
It's looking like autoimmune connective tissue disorders
Why do you say connective tissue disorder?
because it's having a multi-system involvement, waxing and waning course, sir, and adolescent girl with associated with fever, rash, and joint pains.
So you think this is a connective tissue disorder. Any other possibility you thought of at this point of time?
Any malignancy can be a possibility.
Malignancy, which malignancy, where? And why did you think of malignancy in this child?
There is a generalized lymph nodal swelling, sir, and recurrent fever, weight loss.
Is histiocytosis possibility? With that rash, how do you differentiate a rash from histiocytosis with a rash from SLE or other connective tissue disorders? Yeah, how many of you think it's histiocytosis possible in this child? You have joint symptoms, fever, rash on the face, Other symptoms like otitis media, diabetes insipidus can sometimes be associated with histiocytosis.
There's no polyuria, sir. There's no ear
There's no
discharge.
polyuria, there's no polydipsia. Okay, which are some of the
Seborrhea.
features.
Seborrhea in the
Seborrhea.
scalp is very, very prominent. That history is not forthcoming. What are the malignancies which are associated with rashes? Can you give examples other than histiocytosis? Rash and malignancy, what are the possibilities? Since you raised the possibility of a malignant disease, rash and malignancy, can you try to connect the two?
Acute myeloid leukemia.
Acute myeloid leukemia presents with what?
Fever, generalized lymphadenopathy.
No, rash. We are talking about rash and malignancy. You are right in saying acute myeloid leukemia, but can anybody in the audience give the specific answer? Myeloid leukemia is notoriously prone to develop chloroma. Right? Chloromas are very characteristic of non-lymphocytic leukemia. They can present as greenish swelling, right? They can present, in fact, the important differences between a lymphocytic and a non-lymphocytic leukemia in the clinical presentation are: one, superior mediastinal syndrome is very characteristic of a T-cell lymphocytic leukemia. The presence of a chloroma or presence of a gingival hypertrophy, presence of a DIVC, presence of proptosis favor the diagnosis clinically of a non-lymphocytic leukemia. For example, in promyelocytic leukemia, you can have DIVC, you can have gingival hypertrophy, you can have proptosis due to retroorbital tumor in non-lymphocytic leukemia or a chloroma. Right? Any other malignancy in which rash is prominent?
What about lymphomas?
Lymphomas? They can have cutaneous manifestations. Non-Hodgkin's lymphoma can present with cutaneous manifestation. Notoriously, ecchymosis and purpura are very characteristic of any ALL, isn't it? Ecchymosis, purpura. Anything else? Any other? Kaposi sarcoma basically in pediatric HIV is very, very unusual. Neuroblastoma sometimes can have cutaneous secondaries. Right? Okay. Is there any other diagnosis other than malignancy you thought of in this child?
Periodic fever syndromes.
Periodic fever syndrome. Do you think this is periodic fever?
Can be one of the possibility, because rash and recurrent fever, age group.
Does periodic fever present in an adolescent girl like this with fever for 3 months, weight loss, and the child will be essentially well between episodes of fever? And to diagnose periodic fever, you must clearly establish the fact that during the interfebrile period, the child is clinically well.
There's also joint symptoms are not mentioned in periodic fever. And sometimes there may be a family history is also in periodic fever. Those two are absent here.
Right. Any other than periodic fever?
What about other vasculitic disorders, including other vasculitic disorders, polyarteritis nodosa or vaginous? There the rash will be palpable purpura. It will be a non-blanching type of rash, just like your HSP rash. But here it is described as a macular erythematous, what you described as a macular rash.
Acquired immunodeficiency, HIVs. One more.
Is it a possibility in this child?
Can be a possible. Yes, sir.
Is it a possibility?
Yes, sir.
Yeah. How does primary HIV infection manifest in a child? See, for example, imagine this child is a little older, because I hope the parents are not here. Retroviral infection you are thinking of due to an exposure.
Yes, sir.
How does it manifest? Primary HIV infection.
They can have fever with flu-like symptoms initially.
Is it
sir.
fever with flu-like symptoms or fever with something else? Anybody?
Lymphadenopathy.
It presents like a mononucleosis-like syndrome. In fact, You can have fever, sore throat, lymphadenopathy and splenomegaly during a primary HIV infection following some latency after the entry of the retrovirus into the system. It can exactly behave like a EBV like illness. That can happen. Right? Any other possibility? Did you think of any other infection in this child?
Tuberculosis.
Tuberculosis. Is tuberculosis a possibility in this child?
Yes, sir. India being an endemic country, and then tuberculosis can present in any form. Child has been having fever for quite some time, and poor weight gain, oral
Suppose the parents give a history that this child has had fever initially and was then started on ATT elsewhere, and this story is present, what will be your diagnosis? You get my point? Same story, girl, 1 month fever, somebody has started ATT, and the story of the rash, photosensitivity. What will be your diagnosis? You should first think of a drug-induced lupus. Drug-induced lupus. If somebody is receiving ATT and then later on develops, either the initial tuberculosis diagnosis is wrong, or you are having a child who has a drug-induced lupus. Notoriously, anti-tuberculous drugs, pyrazinamide,
isoniazid.
even INH can produce drug-induced lupus.
Also remember, pyrazinamide can cause hyperuricemia, which is a cause of joint symptoms and gout, which is quite often missed unless we check the uric acid level.
Any other infection you thought of, chronic infection, which has multi-system manifestations other than tuberculosis? I think the absence of pulmonary manifestations, absence of CNS manifestations, rash as the primary symptom with photosensitivity, tuberculosis is extremely unlikely unless there is a duo. You can have a SLE with tuberculosis and tuberculosis with SLE. Both can exist together, but that combination is unlikely. If you make a diagnosis, you are unlikely to be right. Right? Any other chronic infection?
Lyme's disease, brucellosis.
No. When you have somebody who has fever with rash for 3 months, what EBV, chronic EBV or CMV infection, notoriously common in immunocompromised children, but can occur rarely in, particularly when you have lymphadenopathy. But arthritis is not common, not prominent, right? So that is another possibility. Any other chronic infection? When you have joint involvement, when you have lymphoreticular involvement, fever, again India, I am giving a clue. What other infection you think of? Cousin of tuberculosis. Tuberculosis mimic. Brucellosis. However uncommon it is, it can present exactly like tuberculosis with non-caseating granulomas with lymphadenopathy. The thing is, rash is unusual. Rash is unusual. Right?
In Lyme's disease, what rash do you get? What is it described as?
Serpiginous.
Erythema chronicum migrans. Erythema migrans. What is the causative agent for Lyme's disease?
Borrelia.
Borrelia.
Can this be a drug fever?
No, sir. That cannot be.
She has been hospitalized 3 times.
Yes, sir.
Which drugs cause this sort of fever, rash, lymphadenopathy? Commonest group of agents which cause fever, rash, lymphadenopathy with photosensitivity with or without arthritis.
Phenytoin.
Anticonvulsants. Everything can occur. DRESS or a pseudo lymphoma syndrome can occur exactly the same way, right? In anticonvulsant induced fever. Can happen. Right? Go ahead.
General exam.
Can somebody get the patient?
General examination. Child was alert, comfortably lying in supine position with IV line in situ in the right wrist.
Thank you.
There is no pallor, no icterus, no clubbing. There is generalized lymphadenopathy. Lymph nodes involved are cervical group of lymph nodes, anterior and posterior, multiple in number, and the largest being 4 into 2 centimeters. Then axillary lymph nodes are also involved bilaterally, the largest being 4 into 2 centimeters, and inguinal lymph nodes are also involved, the largest being 3 into 1 centimeter. These lymph nodes are firm, non-tender, mobile, non-matted, and skin over the lymph node is pinchable.
Is only cervical group of nodes are involved?
Cervical, axillary, and inguinal lymphadenopathy.
Can you describe the rash that she is having clinically? How will you describe the rash?
It's a malar rash, sir. Erythematous.
So describe a malar rash. What is it typically called? What is a malar rash in SLE called?
Butterfly.
Butterfly rash. Why is it called a butterfly?
Because
Distribution of. Describe the distribution. How will you describe it?
over the malar areas and sparing of the nasolabial fold,
Okay.
not involving the periorbital area.
But it involves the bridge of the nose.
Yes.
Continuously is a contiguous fashion. It involves the bridge of the nose. Pairing of the nasolabial folds. It's a fixed rash. Macular with erythematous component. Okay,
Yes.
so that is what a butterfly rash is. And here is a bridge of nose involved.
Not
Some involvement is there, yeah.
yes.
So there is also involvement of perioral region also.
Then vitals. Heart rate is 100 per minute. Respiratory rate is 30 per minute. Maintaining saturation in room air. BPU is 110 by 69. It comes under 50, between the 50th and the 90th centiles according to the AAP charts. Head to toe examination. There is mild thinning of hair noticed on the posterior in the occipital region, but there is no patchy hair loss or alopecia. There is no congestion of the eyes or no corneal haziness. Malar rash is noted, and the nasal, the septal mucosa is erythematous, and palatal ulcer, tiny discrete ulcers are seen over the palate and also in the gingival aspect, and also oral thrush is
Remember,
there.
the palatal ulcer is supposedly very specific for SLE. SLE, they describe the palatal ulcers, very characteristic finding.
And
Is there any nail involvement?
no nail.
Why is it important?
In psoriasis, nail involvement can be
There
seen.
can
Sir.
be pitting of the nails, which can be psoriasis. Okay. Any eye involvement? Have you mentioned about any
Yes, sir.
redness
There's
of the
no
eyes?
no redness of the
There's no
eyes, no
redness
corneal
or-
haziness.
There's no scleritis or uveitis. Is a distribution only in the sun exposed regions or covered areas also?
In covered areas also, sir. Over the chest and the abdomen also, the rash is
Okay.
predominantly seen.
So that is difficult to explain. Characteristically, SLE is supposedly in sun exposed areas.
And papillosquamous rash is noticed over the neck, behind the ears, and over the chest and the abdomen. And
To date, she doesn't seem to have ulcers. What she has is only erythema of the soft palate. There is absolutely no, I can't make out. Now, let me see properly. Use the term ulcer to describe, there must be a break in the surface. There is no break. See properly. I wouldn't accept this as ulcer. It is only erythema. It probably the ulcers, whatever you have seen yesterday, day for yesterday, must have healed. So nervous. Don't be nervous. Okay, come on. Are there ulcers? Take an unbiased look. Chepu. There is ulcer. Are there ulcers now? No. Right. It's okay. It's okay. Sometimes it can happen in the exams also. Within few hours, some arterial rashes might disappear, right?
there are no obvious joint swellings, and no nail abnormalities.
No obvious joint swellings.
No nail abnormalities.
No obvious joint swellings. Ishita, come and have a look. Are there obvious or non-obvious joint swellings here?
That is where P-GALS examination is important, because sometimes it may not be obvious, but a systematic examination of all the joint groups and all the muscle groups is very important. That is part of pediatric gait, arms, legs and spine examination.
What is P-GALS?
It is pediatric gait.
Huh? How do you do it? Can you do P-GALS for her right now? Since Ravi asked you,
No.
can you do P-GALS for her?
Yes.
For the sake of others.
Okay. First, we have to make the child stand.
Before you do anything, what do you do?
We have to take consent.
Take consent one. It's not ASCII, don't worry.
We have to
you have to take consent. You have already taken consent for examination. How do you do a P-GALS examination? What's the first thing you do?
We have to undress her.
No. Anybody? What's the first thing you do in P-GALS? What's the first thing? You ask 3 questions. That is the first thing. First thing, you don't start doing anything. First thing you ask. What are the 3 questions that you ask? Anybody in the audience can help?
Pain.
What are the 3 questions that you ask in P-GALS? You ask 3 questions. One is, you can ask in Telugu, whether there is pain, stiffness or swelling, 3 symptoms related to 3 areas: joints, muscles and back. That's the first question. What is the second question? Anybody? I don't know if you read Nelson, I think. Second is, are you able to dress yourself if it is an older child? Is there any difficulty in dressing up? That's the second question. What's the third question? Are you able to climb the stairs up and down? Can you ask these questions?
నీకు ఇక్కడ పట్టేసినట్టు ఏమన్నా ఉంటుందా? నొప్పి ఏమన్నా ఉందా? నొప్పి ఏం లేదు. నీ బట్టలు వేసుకోగలుగుతున్నావా? పడుకున్నప్పుడు పడుకొని లేచినప్పుడు ఏదైనా నొప్పి ఏమన్నా ఉందా, పట్టేసినట్టు ఏమన్నా ఉంటుందా?
What is the significance of these questions? Why have they given these questions? Anybody? Is it just meaningless? What's the significance of the first question? First question will tell you, see, after all, it is a blind approach to somebody who is suspected to have a rheumatological disorder. By asking questions whether there is pain, stiffness or swelling in relation to muscle, in relation to joint or back, you are localizing the disease. For example, if the child says it is having pain over the muscles, you are going to think of a myositis. If the child says there is going to be pain in the back and stiffness in the back, you are going to think of something like a spondylitis or a disc prolapse. Or if there is pain or stiffness related to joint, you are going to think of a arthritis. It's very important, very meaningful question. Second is, what is the relationship between dressing and rheumatology? Huh?
Small joint and
Simple question.
muscle weakness.
If a child is unable to dress himself or herself, there may be a problem in the upper limb joints, or in these days of tight jeans, etc., there may be a problem in the lower limbs. If the child says, I have difficulty in wearing my sweater, the problem is in the upper limb. The child says, I have problem in putting on my trouser. You know the problem is either in the back or in the lower. You can localize with these questions. What is the third question? Climbing up and stairs. Which portion of the body you are assessing?
Proximal.
Lower limb joints. You know whether there is weakness, whether there is stiffness, whether there is pain. You can make out with these questions. These are the screening questions first you ask. Then how do you do the GALS? What is GALS? What's the expansion for GALS?
Pediatric gait, arm, legs and spine.
Spine, isn't it? How do you examine them?
First,
Demonstrate.
Yes, sir. First,
How do you examine the gait of the child? Demonstrate for the sake of others. Even if it takes some time, it's better. This is very important for us to know. You made her walk, then what do? Walk on the toes and walk on the heels. Okay, right. Is she able to do it? Do you expect a 11-year-old child to walk so slowly? Ask her to do it fast. Okay, walk on the toes. Fast. Okay, she is able to do them well. Right? Gait. Right? Then what next? Arms. Gals, arms. How do you examine the arms, Sri Priya? Examine the arms. Is it normal? How many of you think that this is normal? How many of you think this is normal? Sri Priya, why don't you extend your... Yeah. You are outstretching like a dancer almost, right? Right. And you think hers is normal? No, stretch it nicely, man. Yeah. Is there anything abnormal as you are doing it? What are you observing? See, as you do it, you observe also. What do you observe? See, there are, of course, you find that the muscles in both the forearms are wasted. And look at the wrist. Is the left wrist normal? She is not able, only after suggesting she is able to stretch, she is able to do it. There appears to be some swelling of the left wrist, and she appears to keep the left wrist slightly flexed, and as you are observing, you find that there is minimal fullness of the proximal IP joint. What next? What do you do after asking her to do? No. Ask her to Turn up. Yeah. You are examining the radial ulnar and wrist joints and the forearm, isn't it? Yeah. What next? Arms. Then ask her to touch the little finger, proximate the little finger with the thumb. Then every finger, examining the small joints. What next? No. Before that. Squeeze the wrist and also metacarpophalangeal joint. Then what do you do? Say namaskar. No. That's not the.
No, it's because of the line she is not able to.
She is not able to do it. Namaskar. Then turn it down. Then what? Then arms is not till over.
Stretching up, lifting and touching the wall.
Lifting, trying to touch the roof and look up. You are examining the spine also, cervical spine also. So arms is over, isn't it? Then one more arms is still not over. You have to. You have to bring the hands to the back of the neck. Arms over, isn't it? Then P gals, isn't it? Legs.
And ask her to stand up and touch the toes.
Legs, what do you do? Make her lie down, do it. You can do it here itself. Maybe what do you do in the legs? Anybody? What do you do in the legs? You feel for crepitus in the knee, for effusion, right? And see the flexion of the knee joint. Then flexion of the hip to 90 degree and internal rotation of the hip. That's all. Please do it. See what you do. You feel for fluid in both the knees. Feel for the crepitus. Then do flexion of the knee. Flexion. Yeah. You are able to do it well. Flexion of both the knees. Then flexion of the hip to 90 degrees. Then internal rotation. How do you do internal rotation of the hip? Yeah. Check the internal rotation of the hip. Internal rotation. Yeah. Both sides. That completes examination of the lower limbs. What about the spine, Srilata? Just another 2 minutes before you go. This is very important. Spine. No, before you do that, what do you do? Before you do that, if possible, undress. Then observe the spine from back, front and from sides. Isn't it? To look for scoliosis, kyphosis, gibbous, swelling, deformity, everything you can make out. Right? Then what do you do? Yeah. Try to touch the shoulder, both sides, right and left. Then what do you do? Before that, anything in the mouth? Ask the child to put 3 fingers into the. No, straight like that. What joint are you testing? Temporomandibular joint, right? Then finally, she's not able to completely do it. The back is stiff. Ask her to bend down without bending the knees, without bending the knees. At this age, she should be able to do it. Okay, she's able to do it reasonably, right? Fine. So that is P gals, and you are supposed to complete it in 3 minutes. 3 questions and complete it in 3 minutes. What did you find in her? P gals is normal. You have made out that there is some local problem in the metacarpophalangeal joint and probably in the left wrist. Right wrist you are not able to examine, right? The rest of the joints appear to be form out. Okay? The very purpose of PGALs is to identify which area of the musculoskeletal system is involved for you to perform a focused joint and rheumatological examination. And that should be completed as fast as possible. Right.
So typically in SLE, what joints do you expect to be involved? The large joints or small joints? Which small joints?
Hand joints, hand and foot joints, small joint,
Metacarpophalangeal
phalangeal
joint, and the first proximal interphalangeal joint, and other large joints. In rheumatoid arthritis, what joint is expected to be involved?
both small and large joints are involved.
Okay, so that is important. Which joints are involved? What is the distribution? That also gives you an idea about what could the diagnosis be.
In which disease characteristically there is involvement of the distal IP joints?
So psoriatic arthritis. Anthropometry, weight is 25.1 kg, it is less than the 5th centile. Height is 140 centimeters, it is between the 25th to 50th centile according to the CDC chart. And BMI is 12.8, less than the 5th centile. And Tanner staging is stage 2.
Stage 2 is for what? Describe the components of different standard stages.
Stage 1, there is there is enlargement of the areolar tissue, and there is no hyperpigmentation, no pubic hair, no axillary hair. And stage 2 only there is a breast bud, no axillary or pubic hair. And
it's better to have stages for each component: breast, axillary, and pubic hair. If you read any standard textbooks, you will see the different stages of each component. So here the breast stage 2, axillary hair stage 1, and the pubic hair stage 1. Remember, there is no stage 0. It starts with stage 1. Okay. So is that normal for this child? How old is the child now?
11 years, sir.
11 years. Okay. So it is within the normal developmental pattern. Okay.
Then, sir, systemic examination.
The primary symptoms, you said some swellings in the neck,
Yes,
you never
sir.
described.
I described it, sir. I'll
Please
repeat
describe.
it again.
At systemic examination or general examination?
In general examination, I have given detailed description of lymph nodes.
No, which are the lymph nodes which are involved in this stage?
The cervical group of lymph nodes are involved. Cervical, axillary and inguinal lymph nodes are involved. In cervical, both the anterior and the posterior group are involved. And there are 3 to 4 in number on either side. And each the swelling, the largest of the cervical lymph node are 3 into 2 centimeters. In the posterior cervical region of the right side, and also the submental and the submandibular lymph nodes are also involved. They are firm, non-tender, mobile, non-matted, and skin over the lymph node is pinchable. And in the axillary lymph node also, bilaterally axillary nodes are involved, and the largest being on the right axilla, firm, which is 4 into 2 centimeters. Inguinal, bilaterally, one on the left side and one on the right side, the large oval in shape, and the largest being 3 into 1 centimeters.
Yeah, you said anterior and posterior cervical nodes are palpable.
Yes.
Which node, which group of lymph nodes, if palpable, is more significant?
Anterior, sir, submandibular.
Why anterior is more significant than posterior? Anybody? Why anterior is more significant? Posterior are normally present and enlarged in the age group of 4 to 8 years due to the frequency of
recurrent
infections
infection.
occurring in normal children. On the other hand, the anterior glands are likely to be significant. Whether it is an acute infection or a chronic infection or a malignancy, anterior is more important than posterior. Similarly, supraclavicular is more important than other group of lymph nodes. Right? Commonly, posterior occipital, posterior cervical nodes may normally be present in children belonging to the age of 4 to 8, but not anterior group of lymph nodes. Right? They are significant. They are more significant than the posterior as a rule.
Systemic examinations. So I'll just say the positive findings. Abdomen wise, abdomen is soft. There's no abdominal distension. And spleen is 1 centimeter palpable below the left costal margin towards the splenic axis, and liver is palpable 1 centimeter below the right costal margin, and the liver span is 9 centimeter, which is appropriate for age. Respiratory wise, bilateral air entry is good. Chest is clear. No adventitious sounds. Cardiovascular wise, peripheral pulses are...
No, on chest examination, sorry, what did you expect to find when you say normal? Is there anything that you expected to find in this child?
Tachypnea,
Okay.
Respiratory distress because of serositis.
Okay,
It's possible.
serositis. So, pan-serositis can happen. You can have pleural effusion, pericardial effusion, ascites. So, percussion note is not dull, is normal on both sides.
Yes, sir.
Okay.
Focus.
Is there any pleural rub or a pericardial rub?
No, sir.
You said liver is palpable 1 centimeter below the costal margin. Where? Anterior axial line, posterior axial line, mid axial line, mid clavicular line.
Mid-clavicular lines.
Mid clavicular line. What about epigastrium? Below the xiphoid, is it palpable?
I didn't.
Huh?
I
Do you
didn't.
think it's important to know whether the liver is palpable in the epigastric region, and if so, why?
To rule out any chronic liver disease,
You
if the
must-
left lobe is
you
palpable
must
or not.
mention, make it a point. It's not enough if you simply say 1 centimeter below the right costal margin. You must say the exact place where you found that 1 centimeter below. And you must say whether the left lobe is palpable or not. Because to anybody, if the left lobe is palpable and firm, it could become an important physical finding indicating that there is chronic
Liver.
pathology in the liver. Right? Though you said span is normal, suppose you had found a firm liver, particularly in the epigastric region, left lobe being palpable, it would become very, very important. And again, as what Ravi mentioned, you should mention that you look for signs of ascites. They are not there. I think
Okay.
you should all, anything relevant to the disease or the diagnosis, you must mention without the examiner or anybody asking you. Make it a habit.
Okay. And CNS wise, tone is normal. The upper and the lower limbs both, and reflexes are L-stable. No abnormal movements have been noted.
Anything you found abnormal,
No, CNS examination is normal.
sum up your case and give a diagnosis and differential diagnosis.
Vishnupriya is a 11-year-old female who was apparently well till 4 months back. Later had fever with recurrent fever since 4 months, and rash which is waxing and waning, which is present over the malar aspect of the face, extending all over the body, over the chest and the abdomen, associated with oral ulcerations, and associated with hair fall, and associated with poor oral intake and weight loss. On examination, there is malar rash and papillosquamous rash over the chest and the abdomen, with generalized lymphadenopathy with mild hepatosplenomegaly.
What's your diagnosis and differential diagnosis again?
Sir, it's a chronic multi-system involvement involving the skin and the skeletal system
And the mucous
and the
membranes.
mucous
So the
membranes.
mucocutaneous involvement
Wow.
of what looks like a generalized
Vascular.
musculoskeletal disorder. So what is the most likely diagnosis?
And most likely diagnosis being the connective tissue disorder.
Okay. So out of which, what is common in a girl of this age?
SLE.
SLE is the commonest. Okay. So what are the other differential diagnoses within that group? What other conditions? Juvenile?
Systemic onset juvenile,
Juvenile
idiopathic arthritis.
Arthritis. Okay. Why systemic onset? This is not systemic onset. The joint symptoms have been there also. So it's the monoarticular, polyarticular, or oligoarticular, or polyarticular. So how do you describe? What do you mean by oligoarticular?
Less than
Less
3
than- Okay. So more than 5 joints is
polyarthritis.
polyarticular. Okay. Monoarthritis. So that is how it should be. Don't mention systemic onset here. So this could be a polyarticular type of a juvenile rheumatoid arthritis, rheumatoid idiopathic arthritis. And any other condition in the same group?
Dermatomyositis
Okay, juvenile dermatomyositis. Okay,
and
psoriatic arthritis, but there is no psoriatic lesions. Nail is not involved. Vasculitic lesions, but the rash is not typical of vasculitic disorders. Okay. Fine. Any other differential diagnosis you want to offer?
rheumatic fevers.
Okay, it's not a classical rheumatic fever. There are lot of other features which are against it. Rheumatic fever and Lyme's disease, pediatric fever. We already spoke about all that. Inflammatory bowel disease, Crohn's and ulcerative colitis manifesting with mucocutaneous involvement. So all those come under differential diagnosis. And apart from the musculoskeletal system, any other like malignancy?
Acquired immunodeficiency
Okay.
syndromes.
Yeah. And I think
The
the other things we
malignancy.
already covered, like any malignancy we already covered, possibility of that, and the possibility of tuberculosis we already mentioned about that. Okay. And the chronic illnesses like brucellosis, all those things. Okay. So how will you investigate this child?
We
I'll give the reports first. Pratima or
In the order of
Suprita? Not there. Pratima, please tell the reports, whatever she wants from this case.
In the
You know
order
the
of
reports,
importance, what do you want to know first? Don't tell routine things, just everything in the world. Just in the order of preference, what do you want the first investigation to be, and how will you proceed?
Let her ask. You can ask for the lab investigation. I think Pratima knows the reports.
total WBC count. Hemoglobin, differential count. Hemoglobin, platelets, peripheral smear,
Use the mic. Normal or abnormal smear? Essentially normal. Essentially normal.
peripheral smear. Peripheral.
No blast in the smear, right?
ESR, CRP.
88 ESR, 0.1 CRP.
No, what is the ESR?
88, sir.
88. CRP?
0.1.
0.1.
Urine routine.
Urine routine is normal, ma'am. Urine dipstick is also normal.
No protein. Urea creatinine.
RFC normal.
Liver function test. Then chest X-ray.
Oh, taken outside, I think.
Outside taken is normal.
Normal.
Man 2.
It is done today.
Optal examination.
After examination is normal, ma'am. They have to dilate and see tomorrow.
Use the mic.
They have to
Optal-
dilate and see tomorrow. Otherwise, is normal.
essentially normal.
Ultrasound.
Ultrasound is showing mild hepatosplenomegaly. Rest is normal.
So why do you need ultrasound? You need ultrasound abdomen here.
To look for the kidneys or any altered, any
But
involvement of
urine
the
microscopy is negative. Urine, there's no RBCs, no hematuria.
liver involvement.
How are you going to make out liver involvement when the liver is just 1 centimeter? Certainly, the only thing which can be missed clinically, which can be made out by ultrasound is what? Lymph nodes in the retroperitoneal
Maybe
region.
not.
One more, ascites, minimal free fluid might not be detectable with the best of clinical examination, which might be picked, which could give you a clue that there is polyserositis. Nodes can give you a clue whether there is tuberculosis or lymphoma or even a connective tissue disease. These two findings could be very, very useful. Of course, as Ravi said, urine is normal, urea creatinine is normal. Very unlikely you are going to pick up findings in the kidneys. Right?
Any specific investigations you want to do?
ANA and dsDNA, double stranded DNA,
Double standard DNA, okay,
anti-dsDNA and anti-nuclear antibody.
okay.
Suppose the anti-nuclear antibody in this child comes as positive, what will you do? Negative, what will you do? How will you interpret? The report comes. Report has come, huh? Not yet come. Suppose the report comes as positive or negative. How is it going to change your approach to the patient?
If it is positive, it is definitely a connective tissue disorders.
Definitely. How many of you agree in the audience? Yeah, 20% of normal individuals can have ANA positivity, right? Majority of those with lupus erythematosus have positivity, and ANA is of significance in rheumatology for what? Suppose you diagnose a rheumatological disorder and a child is ANA positive, ANA negative, what is the most important significance to you? A child who has ANA positivity in a rheumatological disorder is prone for uveitis and needs more frequent referrals to ophthalmologist. That's what matters to you. But just because ANA is negative or positive, you are not going to rule in or rule out your rheumatological disorder. Right? It's a highly non-specific affair. What about anti-dsDNA?
That is specific for
Suppose it comes as negative or positive, how are you going to react?
if it is positive, suggestive of SLE. It's more specific.
Yeah, it's confirmatory, isn't it? If it is positive, can it be negative in SLE? When minority of SLE may have anti-dsDNA, particularly when the disease is quiescent. For example, the amount of positivity of dsDNA may correlate with the severity of the disease, and it may vary. And it need not be positive in 100%. I don't know the percentage. If you have read theory, perhaps you can say what percentage usually dsDNA is positive. I think it's around 95%. I don't remember the percentage. Majority will have dsDNA positivity, right? What else will you do?
Bone marrow.
Why should you do bone marrow for this?
We are about to rule out any malignancy, and we are also the child may require steroids, sir. Before
Suppose ANA comes as positive, with these reports, with this clinical picture, will you definitely do a bone marrow? After all, it's an invasive procedure. Because she says there is no pancytopenia. Can anybody answer this question? I think one clue that this is not malignancy so far with the reports what Pratima is giving is a negative CRP. right? A negative CRP in a child who appears to have a multisystem disorder, probably a rheumatological disorder, that too with a rash like this, is almost pathognomonic of SLE. Can anybody tell me why CRP is negative in SLE? Why is it negative? Notoriously negative. In fact, CRP is notoriously negative in SLE, and if the CRP is raised, it indicates a high probability of coexistent or comorbid infection in any child with SLE. Rarely in children who have SLE and who have polycirrhosis, they may have mildly elevated CRP. Interestingly, in literature, what is said is that many of these children have a genetic predisposition to SLE, and many of them do not produce C-reactive protein at all. In fact, the inability to produce C-reactive protein is also implicated in the pathogenesis. They say if there is not enough C-reactive protein in the body, it leads to less of apoptosis. So much so, lot of dirty material from the nucleus of various cells circulates in the serum, and they increase the production of antibodies and auto-antigenicity. That is one of the theories. And last, there are even animal studies which have shown if you give CRP to mice with SLE, I believe they do better. It improves the apoptosis. So there is a fascinating hypothesis. You can even try as a therapeutic, of course not in human. There is a mention. That is very, very peculiar in SLE, that CRP is low, almost pathognomonic. And with this, perhaps I would avoid doing a bone marrow for this child. Is there any other way of getting the diagnosis without doing bone marrow? Some less invasive investigation you can do for this child. Less invasive investigation to get at the diagnosis in case you are going to think of malignancy or even SLE. Skin biopsy. You can do a skin biopsy. Okay, that might give you a clue. But if it is some malignancy, definitely it will show up in the skin, and SLE discoid you can definitely diagnose by doing a skin biopsy. Right? What other investigations will you do if you think of SLE?
We heard of anti-phospholipid antibodies, anti-Rho, anti-SS, SSA, SSB, anchor antibodies. Those are all very advanced, and I think this is not within the, this is all push the limit to very high.
Who can remember those names? Rho,
La antibodies are supposed to happen in Sjogren's syndrome and
only
Stickler syndrome.
one antibody is significant if you think of drug-induced lupus. Which antibody?
Antihistone.
Antihistone. If you think of drug-induced lupus, antihistone antibodies are very characteristic. Other antibodies, yes, SM, Rola, the significance is rarely necessary in routine practice. It's best left to specialists. Right? Yeah. What other investigation will you do if you have diagnosed lupus?
In the renal biopsy, of course, there is no renal involvement here. If there is any renal involvement, renal biopsy will clinch the diagnosis. That is one way of doing it.
Can do what is the significance of anti-phospholipid? It's very important to do. Why? The presence of anti-phospholipid antibody indicate that this child is at high risk of thrombotic complications. It is one of the indications for considering hydroxychloroquine, an antiplatelet therapy in this child. That's important. Perhaps C3 may be useful in the sense it can indicate hypocomplementemia, indicating the possibility of a nephritis. Thyroid function is required. An echo to look for any pericarditis or myocardial dysfunction. X-ray, of course, this will complete the workup.
So echo may show this verrucous endocarditis, which is called Liebman-Sachs endocarditis, which is a rare finding. The only thing I want to mention, I think parotitis apparently is one of the features in SLE. So whenever a child comes with isolated parotitis, one has to think about early manifestation of SLE or a Sjogren's syndrome, in which case the SSA, SSB antibodies may be present.
Can anybody tell me what are the differences in the lupus in children when compared to adults? Ultimately, it looks like lupus. We are waiting for confirmation. Is it right, Pratima? We don't have the tests yet. ANA is not there, anti-DSDNA. And we are just waiting. She's quite stable. She doesn't seem to have renal involvement or cardiac involvement or pulmonary involvement as of now. Right? Eyes are normal. Right? What are the differences between lupus in children and lupus in adults, Srilata?
Discoid lesions are, discoid lupus erythematosus is more common in adults than in pediatric age group, and nephritis is more frequently seen in children.
Anybody? In fact, fever, fatigue, arthritis, arthralgia and skin manifestations are more common in pediatric lupus than in adult lupus. Otherwise, it's the same. It's the same. Majority of lupus in pediatrics presents as fever when compared to other manifestations in adults. Adults can present as anything. In children, invariably lupus presents with fever. That is one difference mentioned in books. Fever, fatigue, arthritis, arthralgia and skin manifestations are specifically mentioned as more common in pediatric lupus, otherwise it's the same.
Okay.
Questions? Yeah. Is there anything, any questions to Ravi or Srilata or to me from the audience? This looks like a classic presentation of lupus.
We have to do echo even though the child is not symptomatic, sir.
As a baseline,
baseline.
you can get
Because
one,
the presence of polyserositis will make you treat the child more aggressively, and for prognosis it could be useful to know. Suddenly, tomorrow suddenly the child comes with some cardiac problem. Can happen. It's a very notorious disease.
Now, frequently do we monitor the child for renal complications?
I don't know all that. I don't know whether
urine routine has to be done once every 3 monthly. I don't think again there's no recommendation. I'm not sure.
Thank you, sir.
So no more questions. We'll close.
No more questions. I thank Ravi and Srilata.
Thank
Give
you
her a
very
big hand for. But I wanted to catch Ashwant, but then I thought I'll catch Srilata.